test April 3rd and still has not gotten results back. I find that embarrassing. There's something wrong with that system. We need to sort that out and figure out what it is. Well, now I'm going to take off my doctor hat for a minute, put up my economist hat, and Dr. Venta, I hope you'll forgive me because I'll probably get some of these numbers wrong. And Henry, pitch in if you want to. But what does this cost us in economic terms? Well, if we've dropped our GDP by 20%, that's a couple of trill, as they say in the biz. That's a couple of trill, no big deal. Of course, when you get numbers that big, they're kind of like fantasy land, at least for me. I have trouble getting my calculator to have that many zeros on it. I use one on my phone. The trick is you turn it sideways, and then you can actually see all the numbers. But I have to go through them a couple of times because I'll mess it up. But a couple of $1 trillion, and if you shift aggregate demand by $1 million, a couple of studies saw this in, it costs 2 jobs in the manufacturing realm and 10 in the service area. So if you do the math, that's a lot of jobs. I think it's like 20 million jobs in service and 2 million in manufacturing. That's a lot of jobs. Unemployment in the Great Recession was 10% on average. That was 2009, I think it was. No, 2002 or 3. It wasn't 2009. 2009, that's right. And then in the Great Depression, on average, it was 14%. It peaked out at 24%, but on average through the Great Depression, it was 14%. And that's breadlines, sports fans. That's breadlines. And right now, we're projected to be much higher, a much higher short-term unemployment rate. So the stimulus package, as wonderful as it might be for some, and I hope that if you guys apply for it, you got it. But the reality is America will be a very different place if we get to 14% unemployment. Again, look back at history. Those who don't study history are doomed to repeat it. And so be cautious about shutting things down, okay? Well, of course, how do you get back? Judge Shelton probably knows more about this than I do, but the reality is it's got to be a regional solution because not every area of the country is at the same point on the curve at the same time, right? It's going to be different from place to place, depending on a lot of things. What are your demographics? What's your average age? What about underlying illnesses? What the susceptibilities of your population are? Do we know what your antibody levels are? That would be very important. A current level of immunity would be very, very helpful in making those types of decisions. So again, those tests need to get here over the next 2 weeks. Next 2 weeks, okay? Crazy. Next 2 weeks. I've dealt with the FDA. Do you know how long it takes to get the FDA to move on anything? It's months to years, okay? So this is record time for America by our history. Could we do better? Maybe. It's going to depend on geography. Are you a travel hub? Do you have an international airport in your area like DFW would be versus Beaumont, which has a much smaller airport? What if you're Kuntz or Silsbee? I mean, do you need the same timeline? No. Do you need the same reaction? No. So this needs to be regionally done based on the data and based on the specifics of your area. Where are you on the curve? What's your immunity? Do we have active therapeutics that actually work? The good news is I think we will, but they're not going to be everyone gets cured. Much like Tamiflu is for influenza, some strains are susceptible, some strains are not. Vaccine for influenza is about 30 to 60% effective in any given year. Now, the good news is it appears that this virus will be one that we can get a vaccine that lasts a while, has durability of immunity, but it's not clear yet. So that's not, we don't have that data yet. It appears to be a virus that we could adapt to a long-term vaccine, but I just don't know that yet. I can't honestly answer that. And again, testing capacity is critical. And a lot of the people that are unemployed presently need to become employed by the Public Health Service to track down contact tracing, to help put people into isolation where need be, and the facilities to have isolation for people who don't have a place to isolate. A lot of poor people can't isolate. They get sick. They go to one room of the house. Well, unfortunately, the attack rate is high enough that probably half the people in the house or greater are going to get the infection. So that's not really isolation, is it? So abilities of municipalities, jurisdictions to come up with some way to restrict activity and to isolate those who are found to be ill or who have been exposed to those who are ill are going to be a really important part of this too. Those are tough. There's a lot of quotes in the news lately. I haven't come on and done my post yet on this, but I'm going to do it pretty soon. The Murray model, Dr. Murray in Washington has done a great job of modeling. So I don't mean to criticize him at all. He was the guy that came up with the 2.2 million, which was brought down to 100 to 240,000, is now at about 60 to 80,000. And that's all good news because that means what we're doing is helping. Now the assumptions in the model are the problem. You assume how many people are actually going to do social distancing. How effective is it going to be? All those are assumptions. So we can't really blame the modeler. He's doing the best he can. But his model now shows that if we were to light switch the economy back on, everybody go to work, see you later, that would be back to current levels of disease by mid-July or August. Now that is 6 to 8 weeks from May 1st. In other words, he's taking the way the virus will pan down over the next 2 to 3 weeks. If we turn the economy back on like a light switch, by mid-July to August, we'll have the same problem we are right now. But remember, that's 6 to 8 weeks. What's happened in the last 5.5? So at 2 weeks, 3 weeks, if you see your numbers going up in your area, you've got to do more to slow it down. And don't forget, it's going to take about 2 weeks for that change that you make to have an effect, because that's the life cycle of the virus, okay? Now, the people in charge, I think, are getting this message, okay? The media doesn't, and they like to make people excitable. But the reality is should be a very controllable situation to come back, and we need to do it because of all the jobs that are lost and the economic oomph that the momentum our economy has lost by taking this prolonged recess. It's a tough balance. And, I'm going to say, give you some tough medicine. Tough medicine tastes bad. Remember that? I'm a kid. When I was a kid, medicine had to taste bad to be good. My children were lucky enough to have Dimetapp, taste like grape, love it. My kids were fake being ill so they could get a dose of medicine, okay? But this is tough medicine, You're going to balance lives and dollars. I mean, we're going to trade people's lives for money. Let me tell you, sports fans, poverty kills people. Poverty is the #1 social determinant of health. And people who live in poverty have much, much worse outcomes from any ailment you want to pick. And all those that the COVID virus loves to kill are upper respiratory infections, obesity, diabetes, heart disease, lung disease, okay? So people will die in poverty. They will. And so that's important to remember. And if you bankrupt 100 million Americans for a decade, I don't think you've really gotten what you thought you were going to get out of it in the lives saved, et cetera. And let me give you another thought. I could save 30 to 40,000 Americans every year if we did one thing, and that would be give up our cars. Are you ready to give up your car? We'd save 30 to 40,000 Americans a year. In fact, the data shows that we've had a lot less car accidents in the last few months because of the restrictions on activity. So are you ready to do that? Are you ready to trade your car for people's lives? I mean, what kind of monster are you to even consider it? Of course you should do that. And don't forget the numbers from this last flu season. If we did exactly what we're doing now, we could do this probably end of September. We could start end of September, hunker down until Thanksgiving. We would probably save 20, 30, maybe more, 1,000 American lives every year. We would call it our fall obligation. Let's just all hunker down for 6 to 8 weeks every fall, and we'd save tens of thousands of people's lives. Are you ready to do that? Are you ready to do that? That's a tough one. Don't answer it. Don't answer it. It's the hypothetical, but it's something you have to think about. So we do need to balance what we're doing with the virus versus what we're doing to the economy and the people that are in it. I'm blessed. My job didn't change much for the virus, but a lot of people can't work from home. And the less educated you are, the less income you have, the more likely your job is to be lost to what's happening. So the effect is magnified on those at the middle to lower range of earnings, okay? So again, there are people in the audience who are probably smarter about that than I am, but that's my big fear, is that we get too enamored with the notion of, hey, if your number of cases ticks up 2% or 3%, you're going to have to shut it down again. I don't think so. It should be manageable. Again, look at the time frame that Dr. Murray's model shows us. 6 to 8 weeks, things return. Okay, after 2-3 weeks, if your numbers tick up, what the number is, I don't know what it is, but 5%, 7%, you're going to have to shut it down again, or do some incremental interaction to lower that. And of course, we need everyone to pitch in and do the right thing. And I don't know what that exactly looks like. There's some smart people gathering to try to sort that out. Do we have restaurants open at half strength only to begin with? If your job is a cubicle job, I put your nails into that one, a cubicle job that's 6-8 feet apart, that might be enough, but maybe wearing a mask when you come out of your cubicle would make sense. If you have a manufacturing setup where you have shifts, maybe shifts are Monday, Wednesday, and Friday, Tuesday, Thursday, and Saturday. So if you get an infected person, you don't expose your entire workforce, like that meat packing plant that you heard about recently. And so those are ideas, just things to throw around. But again, smarter people will make those decisions. But that's the kind of thing we have to do, is staggered return based on your area, and be ready to pull things back if we're unable to control a localized outbreak with aggressive testing and contact tracing. So, boy, I talk a lot. Anyway, that's all I have to say formally. Are there questions? I think that might be a good thing to consider.
Dr. Bost, I have a question for you for the antibody test. Who do you think should first start doing those, and how do you determine? I would like to have it done just to see if I carry the antibodies, but how should we go about that, and what is your direction?
And I probably won't give you a complete answer, but I'll give you some things to think about. I think certainly your frontline people should be tested almost immediately. And the libertarian in me doesn't like the idea of certificates of immunity. That sounds kind of like 1984, but hey, it's 2020. But that type of concept, particularly for health workers, might be a good idea. People who are forced to work right now, like our grocery store people, the workers that are necessary, should probably get tested. And remember, it's not a once only. You're going to get tested, and unless you're positive, you'll get tested again maybe in a week or 10 days. So you have 330 million Americans who are going to need 2 or 3 tests in a month or two. That's a production nightmare for whoever has to make all those up. So I think we've done the right thing with a limited resource, which is test the people who are positive for symptoms, and then try to isolate those that come back positive for the actual illness. But those tests have not been available like they should be. And I think that's probably one of the big criticisms of where we are now. Again, I'm not trying to find fault, I'm trying to understand. And so when this happens next time, maybe we have templates, and it will happen again. I'm hoping it's another 100 years, but it probably be a little closer, because the world's a much smaller place now, right? So I'm thinking 20 to 30 years, this is going to happen again. It may not be as bad a bug. It might be like swine flu, which was bad, but not this bad. But those types of pandemics or outbreaks are going to happen again. So if we can have a template to follow, and that's also on a biochemical level, if we have carriers for antigens and testing modalities that we can plug in the new antigen and just fire it up and run it, those would be smart things to try to develop. But did I answer your question at all? I think frontline workers, people that have to be out in the public for sure, people who are symptomatic for sure. I think we need to do some studies locally, like Jefferson County. We're going to do a random study of 1,000 people and see what our baseline immunity is. Okay, that would be a great use for the antibody test when they first come out. What's my local risk? Because if you've got 30% of people in your area or 40% of your people in the area that are already immune, that's a way different approach than if you only have 5%, right? So I think that would be a really good use for testing. But again, there are people smarter than I am on this who've been through a lot more of this than I have. I'm board certified in public health, which means I've studied it. I haven't lived it like Fauci and Birx have. So those cats should be some good resource for that. So I'm sure the president will listen to them.
Thank you. And it's a great program. We appreciate it.
Thank you.
Dr. Bost, do you think this is the end of the handshake and the hugging at Rotary meetings when you see your friends?
No, and here's why. Like I said, influenza kills people every year. I mean, you saw the numbers. It's horrific how many people die. 40, 50,000 people in a year die of influenza. In America, although we have a vaccine that's about 40 to 60% effective, only a third of Americans get vaccinated every year. Only a third. Okay, so do they care about this illness? They're too remote from it. They didn't see anybody die from it. They didn't get scared to death by the news every day, clicking up yet another 240 people died from the flu today, but that's what the number would be. 240, 260, 300 at the peak of the season, maybe even 500 people die a day from the flu. You don't hear that because the press didn't pump that up. So unfortunately, I think when this thing has gone a year or two, people's memories are quite short. Unless you really saw it in your face, I think unfortunately, people will give up on that. And I like shaking hands. I mean, I was trained to shake people's hands. And if you have a wimpy handshake, I'm not sure I know you or want to know you. And so it's going to be hard to give that up. I think it'll come back, and I think rightly so. But maybe for the next year, it's kind of a, hey, how you doing? Anyway.
Hey, Brent, what do you, I'm asking you about your opinion. I know it's totally speculative, but what do you think is the percentage of us that already have the immunity? That's something that I haven't heard Fauci or Burke really address. And it's quite a difference, as you say, if only 5% of the people have had it, then if 40% of us have had it. What's your thoughts on that?
Well, I think in the New York metro area, it's probably going to be 50%. I mean, by now, because as many infections as they had. But as a percent of the population, the number of people who have actually gotten ill that we can document, of course, that's the problem, can we document, is actually pretty small. And we think that asymptomatic infections, again, hard to guess, 50%, 30%, 60%. I've seen all those numbers. So I think in the New York area, you might have 40% based on immunity when this all said and done. Beaumont, gosh, I mean, how many cases have you guys had? 30, 50?
It hit 100.
100, okay. So probably in Beaumont, it is 5 to 7%. But what if it's 40%? I mean, that'd be crazy. Suddenly like, whoa, I think we're in a lot better shape than we thought we were. Again, you got to be careful and not try to interpret all this to ourselves. But Beaumont may be 10%, Henry. I don't know that. DFW, because it's metro area, probably is going to be higher. New York, if you took New York's numbers off the United States, we'd all be going, what's this about? Because New York is a very unique situation. And just like consumption, the old word for tuberculosis, 150 years ago, was wiping out metropolitan America. And what happened? Everybody went west. Opportunities, you don't die, clean air, hello, not living in someone else's excrement, that's a big deal, okay? So people crammed on top of each other where real estate values are extremely high. People who live in poverty, which may be some of the racial disparities that we see with the illness. Poverty kills, I'm telling you, poverty kills people, okay? And this is an example of how that works. Now, we all hear the stories about the 25-year-old, the 40-year-old, that are all tragic. Every death is important, believe me, from the flu or this. I get it. I mean, I signed up to not let people die. That's the job I took, okay? But I'm just saying that poverty kills people, and this is the reason why. So clean air, good ventilation, good sanitation. If you're in an impoverished family and you're in a very small space and you're supposed to be quarantined or isolated, and you've got no place to send the rest of your family, guess what? Over half of them will get infected also. And that is the real problem. It's the metropolitan areas that have a lot of focused poverty, and in the inner city area, they're going to get the most trouble. The press likes to report those younger people that aren't the older generic with multiple comorbidities, et cetera, because it spooks us, it gets our attention, and in some ways that's really good. But the reality is that this is fairly predictable who's going to get sick, and it's the same people who get the flu. Same people that die from the flu tend to die from this, except not children, which is a bonus of this. Thank goodness it's not the babies that are getting it too, right? And I'm rapidly becoming in that demographic that gets the illness, okay? I'm just saying, every day. But you know, thank goodness, it's the mortality rate is still going to be about a 0.5%.
Dr.
I have a
Bost?
question about the mortality rate too. When it's reported, what I'm hearing is that there's some discrepancy in if a person dies of, if they have a car accident and they die, but they were positive for COVID, they are listed as a COVID death.
In America, that's correct.
That's an extreme example, but that's what I'm talking about. Because a lot of these people, I guess it makes them more susceptible if they are diabetic and not taking their medicine, or if they're, have respiratory issues already. So what, can you say anything about that?
Well, and again, the denominator on death rate has to include people that don't have any symptoms, right? And that's really what we're talking about. Of all those who are infected, who dies? The numerator is who dies. We get all of those. We're reporting all those. In fact, in America, we do report it that way. In other countries, if you were in a certain percentile of heart failure patients, for example, or a certain severity of COPD, emphysema, that sort of thing, they would report you as an emphysema death possibly. And of course, a lot of them aren't tested. That's the problem with the flu estimates. I gave you pretty wide-ranging numbers because those people on a death certificate may not say the flu. It says lower respiratory tract illness, okay? And sometimes they were tested for the flu and sometimes they weren't. So you're right, Sherry, it's very, very problematic. And in this country, we tend to be very diligent about reporting bad outcomes. Not every country does that. I don't know if there's political reasons for that or not. I don't know. We have the same problem with maternal mortality. In this country, we count maternal mortality for any maternal death within a year of delivering your baby. Within a year. Now, is that really maternal? I don't think so. And in fact, if you look at the data, 70% of those maternal deaths are due to drug use and drug overdose. But yet we're supposed to fix that at the I'm delivering your baby level. Again, it's kind of crazy. America's a funny place, right? But yes, I think those numbers are going to distort our death rate up a bit. But again, until I know the denominator, we're just shooting in the dark. That death rate has steadily gone down the more infections we've been able to document. And like I said, Stanford University is going to have a paper coming up very soon. It's going to show that death rate to be very comparable to the flu, about 0.5 to 1%, which should make us feel good about ourselves. I think it's also going to be a lot of support for what Dr. Venta was saying, that what is that denominator? Because, if we knew what the baseline immunity are, and that's baseline infections, how many people had the infection, we didn't even know they had it. That'd be very, very illustrative of where we need to go with coming out of this in each local area. So we need those cross-sectional immunity studies, that's a fancy word, in local area data, so we can parse it down to Jefferson County, Beaumont, get it down to very, very granular, is what Dr. Burns always says, very granular level. We need that.
Dr. Bost, I have a question following up on the antibodies and the immunity. Somewhere along the way, I read a few times that there was not certainty on, exactly whether you get the normal kind of antibodies if you've had this disease. What's your perspective on that?
Well, long-term immunity requires at least like a year or two. So the reality is the diseases hadn't been around long enough. And I think that they're in our business, there are purists and there are pragmaticians or practical people. I think I'm kind of in between, sort of like the FDA treatments. There are no treatments for COVID. That's it. Well, no, whoa. There are FDA-approved drugs that can be used that seem to have benefit, but they've not been proven to show that they actually fix the problem. And I agree with that. It's true, they're not. But if I were dying, I sure the heck would take the drugs that look to be helpful, because what are my options? I'm a purist. I don't take anything that's not FDA approved. Well, 1 in 4 prescriptions in America for any ailment you have are for drugs that are approved by the FDA for use in humans, but not for that specific indication that you're taking. But there's a boatload of evidence to support it, or we wouldn't give it to you, okay? So it would appear by the structure of the virus and comparing it to other viruses with similar type structures that this one is one that's going to be amenable to a vaccine, to answer your question. It appears that way, but you'll hear people say, we have no proof of that. That's not going to be, well, okay. you're right, we don't. I don't have proof the sun's coming up tomorrow, but it's been doing it for a long time. I'm pretty sure it's going to do it one more time. So it's the difference in semantics. And again, a lot of that's political, sadly. And any doctor that gets really political about this and twists the data to fit a political narrative, in my mind, should give their degree up, because you are not helping anybody with that. Stop it. So,
Brent, are you saying that maybe that COVID-19 is just more infectious than other flus, and we still have may end up with the same death rate?
Yeah, and Chuck, thanks for that question. That's a hard one to answer. I'm trying to directly, if I can. If we knew the denominator, we would know that better, right? That's what everybody talks about. We need to know the denominator to know what that death rate really is. And so it's kind of hard to say that. If the baseline immunity is really broad, if this is just the very mountaintop of a huge mountain underneath, then of immunity, then yeah, I mean, this is going to be like the worst flu we've ever had. But if that is more like a pole straight up, like a telephone pole going straight to the top, and all we've seen is the top so far, there's not a lot of immunity below that, then this thing is probably more contagious than we thought it was, or more deadly, or some combination. Whether someone gets sick and dies is a real complex, but also a very simple statement. And that is how virulent, how mean is the bug? How virulent? How much does it do to you that's bad? How does it infect you? In other words, that's an attack rate is what we say. Measles has a 96% attack rate. If you put a measles sufferer into a house full of people who are not immune to measles, by the end of a week, 96% of them will be infected. 96%. That's pretty daggum bad. The flu is down in the range of 20% or so, 30%. And remember, don't forget the flu. The flu, we have some level of immunity from having had the flu 2 or 3 times in our lifetime, because all flu bugs are somewhat related to each other, right? I've gotten vaccinations every year since I was 32, because that was the age when I got the flu the first time, and about I never wanted it again. So if you get serial vaccination over and over and over again, you get enough cousins of the flu that you just don't see as much of it. So we have a third of people getting a vaccine that works maybe 50% of the time. We have a history of having had flu many, many times. So the flu is a tough analogy, because there's a lot of low-level immunity out there that slows the disease down, et cetera, right? So that makes it harder to say. Remember the swine flu when it came through? Very few people over the age of 60 got it. You may not remember that factoid, but it was absolutely true. The reason is that 30-something years earlier, when those 60-year-olds were at the peak of their interaction with other humans, there was a flu bug that looked a little bit like the swine flu, and that gave immunity to people 60 years of age and older. Kind of weird, right? Why don't kids get this illness? Because it's a unique virus. And I think what kills most people with this virus is you have a comorbidity, of course, that's a bad deal. But there's something about your genetic makeup that this virus plus your genes turns on your immune system to beat the living crap out of you. And that's the problem. That's what the respiratory illness is. It's not so much pneumonia. We can treat that with antibiotics. It is the ARDS, acute respiratory distress syndrome, that actually your immune system turns your lungs into mush, and we can't fix you. If you can't repair your lung in enough time to not let the illness overtake you, then you die. And that's the problem. So if you're already really sick, say you have bad asthma, emphysema, bad heart, other conditions, diabetes, obesity, these things that make you not so healthy, then you don't have enough time to recover your lung, to heal your lung, to get over this, and you perish. So the immune system is part of this. People with type A blood may have a slight increased risk of having bad outcomes to people with other blood types. That's very soft data. You didn't hear me say it. But there's some soft data out of China to support that possibility. And I think genetics has a big role to play in this. Why was Italy hit so hard? I remember a family in New Jersey had a family reunion, and it was an Italian family, and there were 16 people there. 9 of them died of the illness within a few weeks of each other. 9 out of 16. You know, so that to me, there's something genetic about this. It's hard to pin it down. Again, these are the post studies that will hopefully do, and this will be PhD papers for people in immunology for the next 20 years, because there's so many questions that remain unanswered. But that's a very good question. Gave you too much of an answer. Sorry, Chuck.
So does it sound like, can you hear me?
Yes, Ted, thank you.
Okay, sorry. Does it sound like basically we're just going to be bouncing along, trying to, stay away from people, and eventually it will decline, and it's not going to be another, and for at least another year to get a true vaccine?
That's a good question. I think that some degree of social distancing will be part of our futures for a long time because we're afraid not to do it. And I think that's probably smart, honestly. Maybe this is the year of I don't shake your hand, you know, that kind of thing. The swine flu, when it came through, the first cases in the U.S. were actually in April. Okay, but it wasn't a thing. It wasn't a thing until the fall. And so the fact that this is hitting us this late in the flu season makes me a little concerned that it will come back again, I think, in the fall. And I think that all the data points toward that. Cases in the southern hemisphere were not that common early on, but now they're stacking up big time while we're all receding. And again, this fits the influenza model because in the southern hemisphere, it's winter, right? So the virus likes cold weather. It survives longer on cold, dry surfaces. Doesn't do as well in warm and humid. So Beaumont, you're home free, baby. Hot, humid, hell yeah. Give me some more of that. That'll help a lot. But yes, it's going to come back in the fall would be my prediction. I think Dr. Fauci said, I call him the Fauci. The Fauci has said, because Fauci and Birx has to be monosyllabic or it's not good, right? The Fauci and the Birx both say the same thing. It's probably going to come back in the fall. We won't have a vaccine by then. I wish we could. But, you know, you can't have one that quickly. You wouldn't know if it was that effective, to be honest.
Right.
There are several therapeutics that are being studied right now that look pretty good. Remdesivir, and then again, the hydroxychloroquine and azithromycin. The preliminary data looks really, really good, but we've been fooled before by that kind of data. So it really may not be that great. But if you have a therapeutic in place, you can let people go back to work a lot quicker. Tamiflu is not perfect, but it helps a lot. But you still with the flu season, with a third of the people getting immunized and having therapeutics that work pretty well, we still have a lot of deaths from the flu every year. So I think we're going to be wise to keep the distancing a bit. Can you go to church? Maybe, but maybe have someone every third spot. You don't stack the place full like Baptists like to do. Since I'm a Southern Baptist, I can talk about them. But maybe you keep your distance. Maybe communion is not getting handed off to you, but you kind of bring yours with you. That kind of thing. So, wise social distancing is still a good idea. And, if we can make it not too artificial, I think families at every other table in a restaurant would probably be doable right now in Beaumont, Texas. That'd be my guess. But you're going to wait 2 more weeks. It's really going to be doable. Okay. But again, the longer you wait, every day you go further down that pipe of people of irrevocable damage being done to the economic momentum that we've built up to this point. Thank God this hit us at the time when the economy is the best it's been probably in decades, right? Because otherwise we'd be crashing a lot lower. Did I answer your question?
Dr. Bost, there's a few questions came in the chat room.
Okay.
Do you know how to pull that up?
No, is it near the bathroom?
No, go down at the bottom where it says,
I see.
on that bottom bar, there's a chat screen, a chat logo icon.
Here we go. Are you as stupid as you appear? I'm not going to answer that one. Let me move on.
See the one you like, answer it.
I'm a slow reader. That's the bad thing. But once I get it in, I'm usually pretty good at it. Some of these were the early ones, I think, that were people just saying howdy.
Do you have an opinion on Dr. Burwinkle's projections from the School of Public Health?
I'm not familiar with those. Dr. Bullwinkle, does he have a show now? No.
Burwinkle, I'm probably saying it wrong.
Burwinkle?
You're sharing your screen.
Uh-oh. So, yeah, I think my other left, so let me get rid of that. That's better, right?
Yeah.
Okay, something happened. I'm not familiar with those projections. There's so many out there, I have to warn you. I really have tried to stay on top of this stuff. but it's been hard to do. Okay, the judge. Thank you, Dr. Shelton, Judge Shelton. 266 confirmed cases in Southeast Texas as of yesterday, 142 in Jeff County, 19 deaths, 9 in Jefferson County, and 29 confirmed recoveries. Thank you for that number. That's one we really need to be paying attention to. A lot of recoveries now. That's great news. And they're probably 10 times more than we are reporting because we didn't know they were sick in the first place. I hope that's what we find out too. Will the saliva test alleviate the problem? It will help because any test modality you can do at the source of the interaction with the potential patient is critical, because if you test people and call them back a week later, or if you did your test on April 3rd and it's now April 15th, so one of you guys has that history, we're not really stopping your contacts for 2 weeks. What did we do? Not much. So yeah, we need on-site testing that's really rapid, and any modality. Think about it this way. If you need to produce 1 billion tests as ASAP, I need 1 billion tests ASAP. If I've got 4 different tests I can make 1/4 of that number of ASAP, it's going to be a lot quicker. So yes, every modality that's effective, that's accurate and available is going to be helpful. We need long-term testing, antibodies. We need short-term testing, you're sick or you're not sick. We need both of those pieces to the puzzle. So everything that comes in is going to be helpful. Yes, let's see. Oh, hold up. You know, I'm hamstringing myself. Here it goes. Yeah, all right. Let's see. Norma Sampson asked, where do you obtain the antibody test locally? The judge may know better than I would, because I really don't know what your resources there in Jefferson County are. You might consider going to your doctor and faking your temperature like I did when I didn't want to go to school. You know, rub your thermometer, you know. See, it's 101 and I've been coughing. I need a test. But I shouldn't promote that. Someone asked about, could we do that with, could we do social distancing with the flu and get good results? The answer is yes, you could. But I don't know that Americans are going to participate. You know, we've already done 8 to 10 weeks, maybe 12 weeks now. Are they going to do it again in the fall? I truly don't think the economy could stand it. But I'm letting you think about that one. Let you think about that. Yeah, Boerwinkle, I don't know. I really don't know. If someone knows the actual projections, that'd be interesting. The models that Dr. Murray puts out there are fine. I mean, he's a very good modeler. The problem is the assumptions may be wrong, and that's where it's really hard to explain that. But like I said, the infection rates, the attack rates, the mortality rates, all those things are wrong because we don't have our denominator yet. And so they come in high and they go down low. Dr. Ioannidis out of Stanford is very well respected. He's got a lot lower numbers than always had. But, you know, this isn't the Price is Right. You know, who can get closest without going over? So you really want to have good data. But, man, poor Governor Cuomo, I've really grown to respect him a lot, because he's going, I need 130,000 respirators, because that's what the model told him he needed, right? You can't blame him for wanting them and for railing against the powers that be for not providing them. Hey, man, he's trying to protect New York, man. And that was the worst place on earth, by the way. And thank goodness he didn't need all he thought he needed. But that is the worst case scenario. I think that's what we're going to see. New York was the worst case scenario because of all the crowding and the people on top of each other, levels of poverty in the inner city, all that kind of stuff. So again, that's all going to be unwound over the next few months. Somebody's going to have to sit up front in church. Yeah, it used to be me before I went bald. It's like, man, I want to sit up front. People see how that bald spot's looking. Okay. All right. A lot of comments. Like I said, I'm sorry that I didn't lose my voice before the talk. Whoever said that, yeah, I get you. No, I'm kidding. No, they were very nice. And thank you for the group for being so willing to listen. I've said some things that may shock you. I hope it makes you think. That's the main thing. And if I offended someone, I don't want to. If you had a friend or neighbor die of the flu or the COVID-19, man, I'm sorry. No one wants anyone to die. Like I said, I took an oath a long, long time ago to try to save people's lives. But there's the immediate effects, and there's the long-term effects, and we got to look at both of those. I'm not a short-term guy. If you disregard the long-term effects of what we're trying to accomplish here, you're going to miss the picture, the big picture. I'm a big picture guy, or at least I try to be. So hopefully I made you think about some things you hadn't thought about, and helped you.
Yeah, Dr. Bost, I want to thank you, Dr. Bost, for the very, very informative program today. We're really, really grateful for your time and being with us today. So to express our appreciation, we're going to make a donation in your name to the Rotary Foundation's to End Polio Now campaign that we have been working on. So we appreciate that, and we're going to have that for you too. Okay, thank you, and thank you for all that you've done for us here. It's a great program today. So let's get to I guess closing here. Please remember to read. This is for our folks here. Please remember to read your Rotarygram that comes as an email to your inbox every Monday. Thank you all who are attending the meeting today. And I want to also indicate some little special here. Thanks for Sherry, Rebecca, and Joanne for what you have done this earlier today. And our tradition, let's close the meeting by saying the four-way test of the things that we think, say, or do. So first,
Is it
Is it the truth?
a second,
fair
Fair to all concerned.
and third,
Will
Build goodwill.
Build better friendships.
and fourth.
Will it be beneficial to all concerned?
Thank you very much. Have a good week, and go out and connect the world. I'm gonna ring the bell.
Bye.
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 Thank you, Dr. Bost.
Bye, everybody. Thank you,
Bye.
Dr. Boss.
Dr. Bost.
Thank you. Thank you. Good to see you all.
You too.
Thank you. Good. He did a great job.
You're the best, Dr. B. Thank you.
Thank you. And if I owe you money, just write me.
Okay, I know where to find you.
You'll find me. That's right.
Yes, it's-